Hello, my name is Lieutenant Colonel Teyhen. I am the Deputy Director of the Telemedicine and Advanced Technology Research Center from the U.S. Army Medical Research and Materiel Command at Fort Detrick, Maryland. Sorry that we're not there today in person, but today I'm really excited to talk to you about the impact of foot type on the cost of lower extremity injury. I appreciate the opportunity to present today, and my colleagues are listed on this slide. As you probably well imagine, the cost of musculoskeletal conditions is staggering, both in the number of individuals affected each year. In the military, it's over 500,000 people. In the number of limited duty days, which is about 25 million limited duty days across the Department of Defense, with a staggering cost as listed on the slide. Almost 80% of these injuries are due to overuse injuries, which may be preventable. So what we need to do is find ways to actually look at who's at high risk for injury and how we might mitigate that risk through proper intervention strategies. And although we understand that risk factor for musculoskeletal injury is multifactorial, foot type is one variable that has been associated with increased injury risk. Specifically, those with low arched feet are more prone to injuries in the middle or the medial part of their legs. They have knee pain. They may have a higher rate of medial tibial stress syndrome or soft tissue related injuries, while those with high arched feet have pain more on the outside part of their leg, knee pain, ankle injuries such as ankle sprains, or bone related injuries such as stress fractures. One of the tools that you can use to actually assess foot type is called the Foot Posture Index 6. This is an observation of 6 different foot types as shown on the pictures, and it's a very reliable tool and easy to administer in a busy military clinic. It also has been demonstrated to be effective in predicting those with higher risk for injury. So the purpose of our study was to determine if you could use the Foot Posture Index and see if there was an association with medical costs for those with lower extremity musculoskeletal injuries, and then describe the healthcare utilization associated with those lower extremity musculoskeletal injuries. So our methods. We recruited 1,000 subjects as part of a larger trial. 332 of those subjects were excluded because they were either not active duty or they left active duty prior to the 18 months. The other 668 subjects were active duty soldiers who were on active duty for at least 18 months after their initial recruitment. Of those, about 50% of them were injured during that 18-month period, and the other 50% were non-injured. It's important to note that we also measured all of our subjects on what's called arch height index, and you can see that we had a normal distribution of arch types across our sample in low, normal, or high arched feet. We then obtained our injury data through a source called the M2 database, which houses all the direct and purchased care costs for healthcare for our beneficiaries. We looked at the ICD-9 codes in the 7 to 900 series, which is related to lower injuries, and we pulled out just those related to lumbar spine and lower extremity injury. The costs associated with that, both in the healthcare system and in the purchased care system if they sought care on the economy. The complexity of the musculoskeletal problem due to using what's called RVUs or relative value units, and the number of visits each individual came for healthcare. And we looked at this for lumbopelvic, hip, knee, leg, ankle, and foot. Our analysis was a one-way ANOVA, looking at the foot posture index categories for foot type, the cost of lumbopelvic and distal injuries, and because there might be a greater association with foot type in just knee and distal injuries, we also looked at it that way. For those that had significant ANOVA, we did post hoc analysis where we determined which foot type had the increased cost, healthcare visits, RVUs, and which lower extremity region. So now is our results. If you looked at our 668 subjects that were with us for the full 18 months, again, 50% of them were injured. We had a little bit more males than females, and the average age was about 30. Their body mass index was just above 25. Just those 50% of those people getting injured cost the system just under $500,000, or just over $400,000, however you want to look at it. But a significant cost for just a very small sample of subjects for an 18-month period. The distribution of those injuries are shown in the colored diagram, where you can see the number one cause of, or cost of injury was lumbopelvic, and the second one was knee and leg. If you look at the cost of of musculoskeletal injury based on foot posture index scores, what you can see is those with a highly pronated foot cost more to the system than those that had a supinated or a normal arched foot. If you look a little deeper, what you could find is that those with knee and distal injuries, and if they were highly pronated, they cost the system more, an average cost of $800 per subject, per injury, where those with a normal arched foot was $300 per injury per soldier, and those with a supinated foot was $200 per injury per soldier. If you look at this graph, you can see that it looks like highly supinated also were increased risk for injury, costing about $500 per injury per soldier. But the problem was that sample size was small enough that that finding was not statistically significant. If you look at just the leg injuries, you find that the pronated feet cost more, of about just under $300 per injury per soldier, compared to the supinated feet, which were under $100 per injury per soldier. And if you looked at the foot injuries, those that are highly pronated cost just under $500 per injury per soldier, where the pronated normal foot were a lot less, closer to $50 per injury per soldier. So from a discussion standpoint, what does this mean? The good news is that you can quickly in a clinical setting look at the foot posture index, identify those that might be at high risk, and those in the highly pronated or pronated category, you can then apply risk mitigation strategies for that. The other interesting thing is that despite the fact that all these individuals had about the same injury rate across foot types, only those in the pronated and highly pronated foot types actually cost more per injury. As I noted in a couple slides back, those in the supinated category and highly supinated category may have cost more, but sample size limited our ability to make those judgments. And to kind of address that sample size issue is to look at a little bit closer those folks that were in our study that were injured. And what you can see is that we had a lot less in the highly supinated and supinated category, and increasing that sample size may have been effective in looking at injuries in this group. So what is our impact on soldier readiness? One, injury rates are much higher in the military than they have been in professional and collegiate sports. Professional and collegiate sports suspect about a 25% injury rate per season, and we're averaging about a 50% injury rate over an 18-month period. The visits associated with these represent a substantial cost on our healthcare system, and finding ways to prevent injuries based on foot type may aid in medical readiness. If you think about this and its impact, if our results are generalizable and you take our small sample size and you bring that out to the larger population of the U.S. Army, knee injuries and distal, including the leg, foot, and ankle, would require a substantial amount of money. So even a 5% reduction in injury would save the Department of Defense over $11 million. So what we're trying to do is find ways to do that. And so our next step is to look at foot pressure distributions and shape and see if we can come up with a very specific combat boot individualized orthotic device that might help mitigate the risk in those that are at highest risk for injury. So in conclusion, pronated feet were associated with significantly higher healthcare costs, healthcare utilization for injuries of the knee and below. And identifying these people may facilitate early interventions, potentially reducing the cost of future injuries. I'd like to acknowledge our funding sources, my research consultants, and the great team of researchers that have helped us accomplish this research study and all in this line of research. I hope you're having a wonderful conference in Milan, and believe me, I sure wish we were there to join you and learn from each other during this international engagement. Thank you very much, and have a wonderful day.